A 69-year-old woman named Miriam came to me 20 months ago. She had been a community nurse for 31 years. She had held the hands of patients through diagnoses that changed everything. She had explained symptoms to families in hospital corridors at hours when nobody wanted to be in hospital corridors. She knew the human body the way most people know their own street, not from study, from proximity, from decades of being close to it when it was struggling, and yet she had missed it in herself. 6 weeks before her daughter brought her to me, Miriam had been sitting at her kitchen table reading the morning newspaper when her right hand went strange, not painful, strange, numb, disconnected. Like wearing a thick glove she had not put on, she had placed her hand flat on the table and looked at it. It had resolved within 8 minutes. She had attributed it to the position she had been sitting in, to a nerve in her neck, to the cool morning air. She had turned the page. 4 days later, standing at the kitchen sink, she had tried to say something to her daughter who was visiting, and the words had not come. She had known exactly what she wanted to say. She could think it clearly, completely. In full grammatical sentences inside her mind, she could not produce it. For approximately 4 minutes, she had managed approximations. Close words, near words, words that were almost what she meant, but not quite. Then it had resolved. Her daughter had looked at her strangely. Miriam had said she was tired and changed the subject. Her daughter had not forgotten. Her daughter had sat with the memory of those 4 minutes for 6 weeks before she found the language to insist. She brought Miriam to me not because Miriam was alarmed. Miriam was not alarmed. She was a community nurse of 31 years who had recognized both episodes, understood them as transient, and filed them under things that resolve and therefore do not require urgent attention. She had applied to herself the same quiet reassurance she would never have applied to a patient. When I sat with Miriam and her daughter and reviewed what had happened, the picture was immediately and unambiguously clear. Miriam had experienced 2 transient ischemic attacks, 2 separate vascular warning events, 2 occasions on which a clot had partially or fully occluded a cerebral vessel, produced neurological symptoms, dissolved, and allowed complete recovery. The hand, the words, both of them warning events from a cerebrovascular system that was telling her something with a clarity and specificity that 31 years of nursing should have made impossible to misread. And she had read them as nothing because they had resolved. Because she had been a community nurse for 31 years and not a patient. And because the single most dangerous feature of the warning the brain sends before a stroke is precisely this. It ends. It goes away. And when something goes away, the human mind files it as a problem that's solved. Did itself. The problem had not solved itself. It had paused. Within 90 days of an untreated transient ischemic attack, the risk of a completed stroke is between 10 and 15%. In the first 48 hours after a TIA, that risk is at its absolute peak. Miriam had been living with 2 unaddressed warnings. Events for 6 weeks. The window during which the most effective intervention could have been delivered at its lowest risk had been passing 1 day at a time while she turned newspaper pages. I'm Dr. Kevin Aduwale. I'm a cardiothoracic surgeon. I spent over 30 years operating on hearts, repairing arteries, and sitting with families in waiting rooms at hours that nobody should be sitting in waiting rooms. I have had conversations with people who survived strokes that did not have to happen, and I have had conversations with the families of people who did not survive strokes that did not have to happen. The distance between those 2 groups, more often than I can comfortably say, was not the quality of care they received after the event. It was what happened in the days and weeks before it. It was whether someone recognized the warning. It was whether someone acted on it while the window was still open. What I'm about to share with you, most doctors won't bring up at your annual checkup, but after 60, it matters more than almost anything else you will hear this year. Today, I am going to tell you about the silent warning the body gives before a stroke, what it looks like, what it feels like, why it is so consistently missed, What is happening inside the cerebral vasculature when it occurs, and what must happen in the hours after it is recognized. Stay with me, because the detail I'm going to share in the middle of this video is the one that explains why even medically knowledgeable people miss this warning. And it is the detail that once you understand it, you will never be able to unknow. Before I describe the warning itself, I need you to understand something about how strokes develop that most people have never been told, because the popular image of a stroke, dramatic, sudden, immediately debilitating, is accurate for a completed major stroke, but it is not the full picture. And the part of the picture it omits is the part that contains the opportunity. The opportunity that closes while people are deciding whether to mention it to their doctor at their next routine appointment. Think of it this way. The brain is fed by a network of arteries, large vessels running up through the neck, branching into progressively finer channels that reach every region of the cerebral territory. Each region of the brain depends on its specific vessel for its continuous blood supply. When that supply is interrupted, when a clot blocks a vessel, when a piece of arterial plaque breaks away and travels upstream, when a vessel in spasm reduces flow below what the downstream tissue requires, the brain tissue that vessel was feeding begins to fail rapidly, irreversibly if the interruption is sustained, at a rate of approximately 1.9 million neurons per minute in a major completed stroke. But here is what the dramatic image of stroke misses entirely. Before many major strokes, the vascular system produces warning events, small clots that temporarily occlude a vessel and then dissolve before causing permanent damage. Fragments of plaque from diseased carotid arteries that travel upstream, lodge briefly in a cerebral vessel, produce symptoms, and then move on or break down before the tissue downstream has died. These events produce neurological symptoms that are real, that are specific, that correspond precisely to the function of the brain region being temporarily deprived of blood. And then those symptoms resolve completely, without leaving any measurable deficit, without leaving any pain, without leaving any obvious reason to seek emergency care. And that resolution is the mechanism by which the warning is missed. The brain said something, the symptom left, the mind moved on. This is called a transient ischemic attack, a TIA. The transient is the word that does all the damage, because transient means it passed, and things that pass do not feel like emergencies. But here is what the resolution does not mean. It does not mean the vessel that was occluded is now healthy. It does not mean the clot that caused the event has gone. It means the specific blockage that produced that specific episode was temporary. The underlying pathology, the arterial disease, the cardiac source of emboli, the carotid plaque that shed the fragment, is still present, still active, still capable of producing another event. An event that may not be temporary, an event that may be the one that arrives with no warning and no resolution, the one that lands someone on my operating table or in my colleague's neurology ward with deficits that do not resolve in 4 minutes. Now, I want to be specific about what the warning actually looks like, because the descriptions people are usually given, face drooping, arm weakness, speech difficulty, describe a major completed stroke. They describe a presentation that is impossible to miss and impossible to explain away the warning that comes before that. The TIA, the silent warning, is quieter, more ambiguous, more easily explained as something else. And it is that ambiguity that costs lives with a regularity that I find genuinely difficult to accept after 30 years in this work. The first presentation of the silent warning is exactly what Miriam experienced in her right hand. Sudden focal numbness or weakness affecting one specific part of the body. One hand, one arm, one side of the face, one leg. The defining feature is focality. It affects a specific, localized region rather than a generalized heaviness or tiredness of the whole body. And the defining feature is suddenness. It arrives without a building phase, without a gradual onset, within seconds. The person is doing something, and then they are doing something with a hand that does not feel like their hand. That is the presentation. Here is why it is explained away so consistently. Because the body produces similar sensations from causes that are entirely benign. Sitting on a leg too long, sleeping on an arm, a pinched nerve in the neck or shoulder. The sensation of numbness from pressure on a peripheral nerve resolves in seconds to minutes and leaves no residual effect. The sensation of numbness from a TIA resolves in seconds to minutes and leaves no residual effect. From the inside, the experience is indistinguishable. The only thing that distinguishes them is the mechanism, and the mechanism is invisible to the person experiencing the symptom. Here is what is actually happening inside the body during a focal numbness TIA. The sensory cortex in the parietal lobe, the region of the brain responsible for processing touch, pressure, and position sense from the opposite side of the body is losing its blood supply. The middle cerebral artery or one of its branches is being transiently occluded. The sensory neurons in that cortex, deprived of oxygen, begin to fail in their processing function. The signal from the hand stops being processed. The hand goes numb. When the clot dissolves or moves, blood flow resumes. The neurons recover. Sensation returns. The episode is over. The artery that caused it is unchanged. The source of the clot, a diseased carotid, a fibrillating heart, a platelet-rich thrombus on an arterial plaque, is unchanged. Everything that caused the episode is still in place, waiting. Research published in the New England Journal of Medicine found that among patients who experienced a TIA and did not receive emergency evaluation, the risk of completed stroke within 2 days was approximately 10%. 10%. Within 2 days, not within months, within 2 days, the window is not generous and it opens only once. The second presentation of the silent warning is the one Miriam experienced at the kitchen sink. Sudden transient difficulty with speech or language, not forgetting a word in the way that everyone forgets words. The tip of the tongue experience that is universal and benign, sudden difficulty. The word is not retrievable at all, or the wrong word comes out, or the person can speak but what they produce does not match what they intended. Or comprehension is affected, the person hears words they know they should understand, and cannot quite resolve them into meaning. This is where people get dangerously confused. Word-finding difficulty is so commonly attributed to aging, to tiredness, to distraction, that the transient language failure of a TIA is absorbed into that familiar category without ever being distinguished from it. But the distinction exists and it is specific. Chronic, gradual, mild word-finding difficulty that has been present for months and occurs in the context of general cognitive slowing is a different phenomenon from sudden, complete, focal language disruption that arrives in seconds and resolves within minutes. The former is a cognitive aging pattern. The latter is a vascular event. They feel similar from the inside. They are categorically different in their implications. Here is what is actually happening inside the body. Pray language in the brain, in most right-handed adults and many left-handed ones, is controlled by the left hemisphere, specifically by Broca's area in the frontal lobe, which governs speech production, and Wernicke's area in the temporal lobe, which governs language comprehension. Both regions are supplied primarily by the left middle cerebral artery. When that artery or one of its branches is transiently occluded, both language production and comprehension can be affected simultaneously or separately, depending on which branch is involved. The person knows what they want to say, the semantic content is intact, but the neural machinery required to produce the phonological sequence fails. Words become inaccessible, speech becomes effortful, approximate, wrong. Then the clot moves, blood flow resumes, language returns, the episode is over. That episode is not a senior moment, it is a stroke warning. And the two have been confused in the lives of too many people I have met after the warning passed unrecognized and the stroke arrived without one. Let me ask you something directly. Has there been a moment in the past year, even briefly, even for 2 or 3 minutes, when words did not come the way they always come? When you reached for a word and found nothing where it should have been, in a way that felt different from ordinary forgetfulness. When someone you love spoke to you and their words did not quite land, tell me in the comments below, because the number of people watching this video who have experienced a transient language event and given it a name that required no further investigation is far larger than it should be. The third presentation of the silent warning is vision, and this one is the most likely to be seen by an optician rather than a neurologist, which means the most likely to be investigated through the wrong pathway at the wrong speed. Sudden transient vision loss in one eye. Not both eyes. 1. A darkening or graying of the visual field in one eye that arrives suddenly, lasts seconds to minutes, and then resolves completely. Sometimes described as a curtain being drawn across the eye from above or from the side, sometimes described as a smudge that was not there before. Sometimes described simply as the eye going dark for a moment. This specific symptom has a specific name, amaurosis fugax, and it is caused by a specific mechanism that connects it directly to the cerebrovascular system in a way that most people and some clinicians outside cardiology and neurology do not appreciate. The ophthalmic artery, the artery supplying the retina, is the first branch of the internal carotid artery. When atherosclerotic plaque builds up in the internal carotid, fragments of that plaque can break off and travel upstream into the cerebral circulation. The ophthalmic artery, being the first branch encountered, catches these fragments. The retina loses its blood supply temporarily. Vision in the eye fails when the fragment moves on or dissolves. Vision returns. Here is what that means for cerebrovascular risk. The eye has just shown you what the brain has been narrowly spared. The same carotid that shed the fragment that went to the ophthalmic artery is also the carotid feeding the ipsilateral, the hemisphere. And of the brain, the next fragment may not go to the ophthalmic artery. The next fragment may go further into the middle cerebral artery, into the anterior cerebral artery, into a vessel whose territory, when infarcted, does not recover in 4 minutes. Research from JAMA Neurology confirmed that transient monocular vision loss from a presumed vascular cause carried a 90-day stroke risk of 8 to 10% without treatment, and that with appropriate and timely intervention, that risk could be reduced by more than 80%. 80%. The window for that reduction exists from the moment the symptom occurs. It closes 1 day at a time while the person books an optician appointment for 3 weeks later. If vision goes dark or grey in one eye, suddenly, briefly, for any duration, go to an emergency department that day. Not an optician, not a GP appointment, an emergency department. Say these exact words. I had sudden transient vision loss in one eye. Those words will get you a carotid ultrasound, a cardiac assessment, and a neurological review within the correct time window. They will get you antiplatelet therapy and the investigations that identify the source of the emboli and allow it to be addressed before it produces a stroke that no intervention can undo. The fourth presentation is the most overlooked of all. Not because it is subtle, but because it is the most familiar sensation in the repertoire of symptoms that older adults dismiss without investigation. Sudden severe dizziness, or sudden loss of balance, or a sudden difficulty walking, an unsteadiness, a veering, a loss of the coordination that makes walking the automatic background activity it has always been, that arrives without warning and resolves within minutes. Every older adult has experienced dizziness. Dizziness when standing too quickly. Dizziness from inner ear crystals shifting. Dizziness from blood pressure medication. Dizziness from dehydration. The list of benign causes is long and familiar, and because it is long and familiar, dizziness is given the least urgent clinical attention of any symptom in this age group. It is the complaint most likely to generate a reassurance rather than an investigation, and in the specific context of sudden, severe, new quality dizziness associated with loss of balance, it is the symptom most likely to represent a posterior circulation TIA, the territory of the vertebrobasilar system. The cerebellum, The brainstem, some of the most dangerous vascular territory in the entire cerebral system. Here is what is actually happening inside the body. The posterior circulation of the brain, the vertebral and basilar arteries and their branches, supplies the cerebellum, the brainstem, and portions of the occipital cortex. The cerebellum is responsible for coordination and balance. The brainstem controls consciousness, breathing, swallowing, and the regulation of heart rate and blood pressure. When ischemia affects the posterior circulation, the presentation is not the classic face drooping and arm weakness of the anterior circulation. It is dizziness, vertigo, ataxia, and inability to coordinate movement normally, difficulty walking in a straight line, and in some cases double vision or difficulty swallowing as the brainstem itself is transiently affected. A multi-center study published in Stroke found that posterior circulation TIAs were significantly more likely to be missed or misdiagnosed on initial clinical presentation than anterior circulation events, and that the rate of completed stroke within 90 days in missed posterior TIA cases was meaningfully higher than in those correctly diagnosed and treated. The dizziness was dismissed. The brainstem infarction followed. If sudden severe dizziness or loss of balance arrives without a clear positional or mechanical cause, particularly if it is accompanied by any other symptom from this list, or if it is qualitatively unlike any dizziness you have experienced before, please do not attribute it to your inner ear and manage it with hydration and early nights. Go to an emergency department. Tell them it was sudden, severe, and associated with difficulty walking. Let them decide whether it is inner ear or brainstem. That decision requires imaging. It cannot be made from the history alone. Let me bring together what the silent warning looks like in its full presentations: sudden focal numbness or weakness in one hand, one arm, one leg, one side of the face, arriving in seconds, lasting minutes, resolving completely. Sudden transient difficulty with language producing words, finding words, or understanding speech, arriving suddenly, lasting minutes, resolving completely. Sudden transient vision loss or dimming in one eye, arriving suddenly, lasting seconds to minutes, resolving completely. And sudden severe dizziness or loss of balance, arriving without a clear mechanical cause, lasting minutes, resolving completely. 4 presentations. All of them transient, all of them resolving, all of them carrying the same message from the same source. Something inside the cerebral vasculature produced that event. The source of that event is still active. The next event may not be transient. And the window between this warning and the next event is the window that determines whether what comes next is a TIA managed in a stroke prevention clinic or a stroke managed in a rehabilitation unit. Knowledge without action is just worry. And I am not here to make you anxious. I am here to give you a plan. The plan is simple. Simpler than most people expect when they have just been told that something they dismissed as nothing was a warning before a stroke. If any of the 4 presentations I've described occurs to you or to anyone near you, call emergency services immediately. Not a GP surgery, not an urgent care clinic, not a plan to see how you feel tomorrow. Emergency services, the phrase to use, the phrase that will get you the right assessment in the right time frame in both the US and the UK is, I think I may have had a transient ischemic attack. Those words change the speed of everything that follows. They get you a stroke protocol. They get you brain imaging. They get you antiplatelet therapy and carotid imaging and cardiac monitoring within the window in which those interventions reduce your subsequent stroke risk by the most. After TIA, the 2-day stroke risk is at its peak. The investigations that must happen in that window, a diffusion-weighted MRI to identify any small completed infarction, a carotid ultrasound to identify significant stenosis that may require surgery, an ECG and cardiac monitor to identify atrial fibrillation as a cardioembolic source, blood pressure assessment and management, antiplatelet therapy initiation. All of these must happen urgently, not at your next routine appointment, not when a slot becomes available urgently. And they happen urgently only if the emergency presentation is made. For those who've experienced something in the past, something that is already resolved, that was weeks or months ago, that was explained as something else at the time. Call your GP today and describe it using the language I have given you. Sudden, focal, transient, resolved. Those 4 words together in a description of any neurological symptom will prompt urgent review, and that review, even weeks after the event, can identify the source, quantify the risk, and initiate the protection that reduces what comes next. I want to come back to Miriam. After her daughter brought her in, the investigation was rapid and specific. Her carotid ultrasound showed 74% stenosis of the left internal carotid artery. Her MRI showed 2 small areas of completed infarction, small strokes that had already happened silently, producing no residual deficit detectable in ordinary life, but visible on imaging as evidence of what the warnings had been. Warning about: she underwent carotid endarterectomy, surgical clearance of the carotid stenosis, within 5 days of presentation. She was started on antiplatelet therapy, a high-intensity statin, and tight blood pressure management. Her subsequent stroke risk was reduced substantially. 8 months after her surgery, she came back to see me. She sat across from me in the way that people sit when they have had time to think about what they want to say and have decided to say it plainly. She said, "I spent 31 years teaching patients to take their symptoms seriously." She paused. Then she said, "I gave myself every explanation I would never have given them." That sentence has stayed with me ever since. It is a large part of why I make these videos. Because the warning the brain gives before a stroke does not fail. The brain is remarkably consistent in what it sends. What fails is the recognition. What fails is the decision to act during the window rather than after it. And what most consistently prevents that recognition is the single feature that makes the TIA so specifically dangerous. The resolution. The fact that it ends. The fact that ending feels like resolution rather than what it actually is, a pause. Let me say each presentation one final time. Sudden focal numbness or weakness in one specific part of the body, one hand, one arm, one side of the face, arriving in seconds, lasting minutes, resolving completely. Not a pinched nerve. A warning. Sudden transient language failure, words not coming, wrong words arriving, comprehension briefly failing, arriving suddenly, lasting minutes, resolving completely. Not a senior moment. A warning. Sudden transient vision loss in one eye, darkening, graying, a curtain drawn, arriving suddenly, resolving completely. Not tired eyes. A warning. And sudden severe dizziness or loss of balance without a clear mechanical cause, arriving without warning, resolving within minutes, not inner ear. Potentially, a warning. 4 presentations, 1 action. Emergency services, immediately, the same day, the same hour, every time, without waiting to see what happens next, because what happens next is determined by what you do right now. Which of these presentations have you or someone you care about experienced and explained away? Tell me in the comments. I read every single one, because those answers tell me how many people are carrying a warning they have not yet acted on. And that number changes every time someone shares this video with the right person at the right moment. If this video gave you something, a recognition, a concern, a reason to make a call, share it. Not for me. For the person in your life who had a funny episode last month that went away, who noticed their hand for a moment at the kitchen table and said nothing, who cannot quite explain to you what happened with their words at dinner last week, but insists they are fine because it resolved. They may not know what the resolution means, but you do now, and that is exactly why you are here. And if you have not subscribed yet, please do. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. If you are experiencing any of the symptoms described in this video right now, stop watching and call emergency services immediately. Do not finish the video. Do not call a family member first. Call. Time is the variable that determines the outcome, and the time is now.